Thank you. It is my honor to introduce Dr. Arie. He earned his medical degree and did pathology residency at UT Southwestern. Afterwards, he did surgical pathology and neuropathology fellowship at the Mayo Clinic with the preeminent Dr. Bernd Scheitauer. And his work there helped define how we grade meningiomas. He subsequently spent time at Washington University in St. Louis, where he won numerous distinguished service teaching awards before moving on to become the chief of neuropathology at UCSF. He's also served as the president of the American Association of Neuropathologists and has authored numerous textbooks, including the prestigious Greenfield's Neuropathology. On a personal note, I was honored to learn from him as a neuropathology fellow at UCSF, and I can say he's truly a thought leader in the field of neuropathology. One of my favorite facts that he knows I can't withhold is his love of singing, both classical music and songs of his own design, of which Brain Tumor Rhapsody is one of my favorites. And so for those of you who have time after this, I strongly encourage that you Google Arie Perry and Brain Tumor Rhapsody. It will be well worth your time. And with that, I know all of us here at Duke and across the country are really looking forward to your presentation. So thank you.
Okay, well, thank you very much to the organizers and to especially Duke for hosting this. This is the first time I'm doing a virtual Grand Rounds. I think it's a great idea. So I suspect we'll be seeing a lot more of these in the future, especially given the situation we're all in. So I'm going to talk a little bit about the last WHO classification scheme for brain tumors and the updates that have come out, been published since that time, and we'll tell you that actually the newest WHO is just starting now. So I will hopefully get us right up to that point, and then in the next few months or year, we will hopefully have a new version that we can discuss as well. So I have no disclosures, as was mentioned. All of us do pattern recognition, and sometimes we get teased about that, but of course you don't have to be a pathologist to do pattern recognition. And so for those of us who are at least of a certain age in the audience, when I put this up, you immediately recognize this as Elvis Presley. And the amazing thing to me is, of course, we didn't have to do any morphometry or any DNA analysis. Within a split second, your brain tells you this is Elvis Presley. Takes a bunch of morphologic clues and tells you this is Elvis Presley. So pattern recognition is incredibly valuable and powerful. But of course, it also has some problems with it. And those of you who are pretty astute may have noticed that the two here that are outlined are actually not Elvis Presley at all. They're Elvis Presley impersonators. And sometimes the brain tumors that we encounter are like this as well. And we may see two tumors that look remarkably similar, and yet the behavior is completely different. Of course, another problem that we all face with pattern recognition is that sometimes we get mixed messages, and we're not quite sure which direction to go with these mixed messages. So for all these reasons, we've turned to molecular pathology to help us out. And as you probably know, there's been a revolution in molecular pathology over the last at least 15, 20 years. But it's really accelerated in the last decade. And this has applied certainly to neuropathology as it has to many other fields. So to give you an example of what I mean, if you take one diagnostic entity like glioblastoma, this was a study in 2012 by a German group. And they did genomic analysis on these cases and epigenomic analyses, and they find that if you look at glioblastoma, it's not a homogeneous disease molecularly, and in fact, there seems to be at least 6 subtypes molecular subtypes of glioblastoma, and we're going to talk about some of these along the way. But you'll notice there's all kinds of differences. Some are in much younger patients, some in older patients. This one has a particular predilection for midline structures, and the prognosis is quite different among some of these than others. So we really have to stratify some of these cases. The ones that I've put with green boxes at the top here are ones where we actually have immunohistochemical surrogate markers that we can use to help us detect these subtypes. Now, I know you probably can't read this. This is too small. This is a table that came out of a textbook that I'm one of the editors of that's a pattern-based approach to diagnosis. And in the last edition, we added a chapter on molecular patterns. And so the take-home message of this slide is that there's now at least 50 or 60 different entities among brain tumors that have genetic signatures that are fairly unique. So with this kind of background in mind, back in 2014, we had a pre-WHO meeting to start discussing, similar to what hematopathologists have been doing for quite a long time, but we hadn't. How can we start utilizing molecular definitions into our WHO classification? And so we had a number of experts from around the world, and we published a paper with our findings, and one of the things that we suggested was that diagnostic entities should be defined as narrowly as possible. So with this in mind, I have to tell you that a couple of months ago, I was amused when I got a package in the mail and found out that someone had decided that I am actually the director of neuropathology instead of neuropathology. But in any case, one of the things that we had decided, or we had kind of proposed at this meeting, was that we should approach our diagnoses with layers, similar to what you get when you look at a Google map and you have different layers of information all stacked on top of one another. So, for example, when we look at a slide, the first thing we do is the histologic impression or classification. We have a WHO grade that's assigned to it, which typically should reflect the natural history. And now we add all types of molecular information to this. If we put all these together, we integrate these all different pieces of information, and we get a integrated diagnosis. Let me go back. That incorporates all the aspects of tissue diagnosis that we normally do. So the following year, we had another meeting, this time in Heidelberg, to kind of iron out all the remaining controversies of classification for what became the WHO 2016. And here's a photo of the group, which I particularly like because it looks like we're all kind of gazing up into the heavens looking for some divine inspiration, which hopefully we got, and hopefully got things right. But the good news, of course, is that every few years we get another chance to get it right. So here is the WHO 2016, and the things that really changed dramatically were the classification of gliomas, and you can see here that some of the genetic things have been incorporated, especially IDH status, and we'll talk about what that means a little later. The embryonal tumors in pediatric practices also changed quite dramatically, and we'll talk about those. And at least one new ependymoma variant was added with a molecular definition included. So it was also recognized that things are now moving incredibly quickly, and it's really hard to keep up. And so of course, the WHO previously was published every 7 to 10 years, and things changed dramatically over that time. So we established a group that basically would publish some updates along the way as things moved in the field moved forward. And it's called cIMPACT-NOW, which stands for the Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy. So quite a mouthful. The NOW actually stands for not officially WHO, which I think is a little bit of a joke because if you look at the list of participants, it's almost identical to the people that are involved in the WHO. So I would just say that it's highly likely that we will eventually accept our own uh, recommended guidelines. But at least until the next WHO, these are not officially endorsed by the World Health Organization. So how do we incorporate molecular criteria into the definitions? It's really all based on basic biomarker concepts that all of us utilize on a daily basis. And as you all know, biomarkers come in 3 different flavors for the most part, and they can be more than one at the same time. Diagnostic, prognostic, or predictive. And because the WHO is basically a guide to making diagnoses, we focused most on the diagnostic biomarkers, though of course we mention the others as well. It's just that some of these don't necessarily go in the diagnostic line. We still do them, and they're still part of standard of care. And then the other thing that's very important when we put these together was to consider the fact that this is, of course, the World Health Organization. So this is a system that has to be used throughout the entire world. There are rich countries and poor countries, and we don't all have the same resources. And so we knew that at least for most of the world, immunohistochemistry is available to probably over 95% of pathologists. So whenever possible, and we had immunohistochemical surrogate markers, we tried to emphasize those. So I'm going to kind of take you through chronologically what we've learned over time and how we're using some of these biomarkers. So one of the first things that was identified back in the 80s, I would say, is EGFR gene amplification. We knew was very common in glioblastomas. Also, gain of an entire chromosome 7 and loss of an entire chromosome 10 was another signature marker of GBM. So if you think about it, this is definitely, both of these are diagnostic markers, and they're going to come into play a little later into how we use them. They're really not prognostic markers for the most part, and people have been trying to work on therapies targeting these things, but I would say at this point for routine clinical care, they're not predictive biomarkers because we have yet to identify really effective targeted therapies. Another big advance came in the late 80s, early 90s, when people identified a signature for oligodendrogliomas that involved loss of the entire short arm of chromosome 1 and the entire long arm of chromosome 19. And for a long time, we taught that this was the one biomarker that's all 3. So it's diagnostic, it's associated with oligodendroglioma diagnosis. It's prognostic because those tumors do much better than other gliomas. And it's predictive because patients with these tumors tend to do better with alkylating chemotherapy agents and have longer survival. But now I would say this has now become part of the definition of this entity. So really it's a diagnostic marker. It's no longer prognostic and predictive because 100% of oligodendrogliomas by definition have to have 1p19q codeletion. Another big advance came in 2008. This is one of the ones that I think changed our daily practice more than anything else. And this came out of Duke and Hopkins and others, where a genomic study was done on glioblastomas, and many of the alterations we already knew about were validated, but at least one was a big surprise to people. And that was mutations in isocitrate dehydrogenase 1, also known as IDH1. This is an enzyme in the Krebs cycle that most of us memorized back in medical school and then quickly forgot. But it turns out that these GBMs that had these IDH1 mutations, those patients had a better prognosis and did better. They also tended to be younger patients, and they tended to arise from lower grade astrocytomas that then eventually progressed to GBMs, what we previously called secondary glioblastomas. So when people started looking at lower grade gliomas, lo and behold, it turned out that in fact this was the single most common mutation in grade 2 and grade 3 gliomas, regardless of whether you're talking about astrocytomas or oligodendrogliomas. And so this is probably one of the driver mutations in a very big category of diffuse gliomas. Most of them involve IDH1. There is a homologous gene, IDH2, that is involved in a smaller percentage, about 5% of diffuse gliomas. So it turns out that about 90% of all the IDH1 and 2 mutations involve a single point mutation in the IDH1 gene that converts arginine to histidine and amino acid 132. So we call it IDH1 R132H. And there is a very sensitive and highly specific immunostain that can detect this point mutation, or the protein product of this point mutation. And so we all use it nowadays virtually on all of our diffuse gliomas. And it's very useful, number one, as a diagnostic tool. Here's an example of how that happens. One is in the old days, and even now to a certain extent, we often had this problem of something that is suspected to be a low-grade glioma, but is not very cellular and only has these rare atypical nuclei. And in the old days, we'd say, well, it's atypical, I'm suspicious, but I'm not sure. If we do the immunostain and we find that there are immunopositive cells, by definition, that is a glioma cell. There is no reactive process that will no reactive astrocytes or other process that will be positive with this immunostain. So it's incredibly useful. It's a great screening tool. Picks up about, as I said, almost 90% of all the IDH mutations. So at this point, it's mainly a diagnostic tool. It's somewhat prognostic because those tumors do quite a bit better than IDH wild-type gliomas. Although, again, similar to oligodendrogliomas, it's part of the definition now for a group of these gliomas that we defined in the WHO 2016. It's not a predictive biomarker at this point, although certainly people are working on IDH inhibitors and other targeted therapies, so perhaps one day it will be. So here's another diagnostic area where it's useful. So I use that analogy again of the Elvis Presley impersonator. And until the 2016 WHO, this was a very common problem. And that is that one subtype of glioblastoma, the small cell glioblastoma, had tremendous overlap, morphologic overlap with anaplastic oligodendrogliomas. The difference, though, is that these patients have an average survival of 15 years with therapy. These patients still have an average survival of only about a year. And the clinical trials, of course, are quite different. Now, this is an easy distinction because, by definition, Anaplastic oligodendrogliomas have to have IDH mutation and 1p19q codeletion. 100% of these small cell GBMs are IDH wild type, so very easy distinction to do nowadays. So remember I mentioned that we only pick up about 90% of the IDH mutations with the immunostain, so it's a great screening tool, but the question is then when do we reflex to doing sequencing of the IDH1 and 2 genes? And the most common scenarios is when the patient is young, in this case defined as less than 55 years of age. Those patients have a much higher chance of having mutations, whereas over the age of 55, the yield of testing is less than 1%. So most people will not reflex to those cases over the age of 55. Also for me, when I see classic oligodendroglial histology, those more often have IDH2 mutations than the astrocytomas. So even if it's negative, I usually will do it. Or as we'll talk about in a minute, loss of ATRX expression regardless of age, then I will reflex to IDH1 and 2 sequencing. Okay, so another development that we've known about for quite a while, but really was elucidated with gliomas more recently, is what are the mechanisms that all cancer cells use for escaping senescence and becoming immortal? And there's two major ways. There's probably more than these two, but at least two major ways that cancer cells throughout the body do that. One is through telomerase overexpression, which we've known about. Hold on a second. Okay, sorry. Telomerase is one of the common things that occurs with glioblastoma, and but we never really understood what the mechanism was until recently, and I'll go over that in a minute. Another one is alternative lengthening of telomeres, which occurs in about 10% of cancers. Turns out in gliomas, these two mechanisms are highly associated with specific molecular subtypes of gliomas. So it turns out in the GBMs, it was only in the maybe 2012-13 that we finally identified what was the mechanism of overexpression of telomerase. And it's a point mutation, one of 2 point mutations, but not in the coding region of the human TERT gene, but in the promoter region. And it turns out here are the different cancers throughout the body that use this mechanism. And in neuropathology, ironically, one of the worst behaving tumors, primary GBM, is the most common one that uses this mechanism, and then oligodendroglioma, which has a favorable prognosis, also uses this mechanism. And it turns out instead the alternative lengthening of telomeres is used by IDH mutant astrocytomas and a couple of other subtypes of astrocytomas. And virtually always the mechanism for this is a mutation in the ATRX gene involved in chromatin maintenance. And we have a surrogate immunostain for that as well. And so this is the normal. The normal is that all nuclei should express ATRX. But if there's inactivation by mutation or other mechanisms, you have loss of expression in tumor nuclei. Now, I will tell you, if you're using this immunostain, it can be quite finicky. And so you really need to look for the internal positive control. So endothelial cells and trapped neurons and trapped normal glial cells should all be positive. If everything is negative, essentially that's a technical failure of the immunostain. It's not a loss of expression. So it's really very useful. The third marker that I really didn't talk too much about, but is also highly often involved in IDH mutant astrocytomas, is the TP53 gene. In this case, it causes usually overexpression of protein in, or stabilization of the protein in nuclei. So if we get a situation like this where immunostain shows that there's expression of IDH mutant protein, overexpression of p53, and loss of ATRX, essentially we're done with just immunohistochemistry. That is by definition an IDH mutant astrocytoma. Now we're not finished. We still have to grade these tumors using histology, and they can be grade 2, 3, or 4. But that is essentially an IDH mutant astrocytoma, and we don't have to do any further molecular testing. This turns out not to be, like many things, not to be completely true with pediatric cases. Similarly, with IDH mutant and 1p19q co-deleted oligodendrogliomas, most of the time they're positive with the immunostain for IDH1, usually minimal p53 expression and retained ATRX. Now, we still have to do FISH or LOH or next generation sequencing or something to show that there is 1p19q co-deletion, and preferably, if you have a mechanism to show it, whole arm loss of 1p and 19q. I will tell you though, if it's histologically a classic oligodendroglioma and you have this immunoprofile, it's virtually 100% of the time that you're going to find 1p19q co-deletion. So what about pediatrics? So I'll just go quickly through that. So like many things, it turns out that kids are not just small versions of adults, and they have their own different molecular mechanisms for the tumors that they get. So in the diffuse gliomas that we see in children, the astrocytomas most often involve the MYB and MIB-L1 genes, the oligodendrogliomas, and several tumors that have oligodendrocyte-like cells most often involve the FGFR1 gene. Gangliogliomas involve BRAF typically, and then there's a small subset, most often in teenagers, that have the adult type IDH mutant types of gliomas. There's a new entity that was introduced in the 2016 WHO called diffuse midline glioma, H3K27M mutant. These are one of the few tumors that is by definition grade 4. It has no grading criteria. They're all grade 4. So instead of IDH mutations, these have mutations in histone 3, and they convert lysine to methionine and amino acid 27. Like the situation with IDH1, we now have immunostains that can identify the mutant protein in these tumors, and so immunohistochemistry is quite useful. Typically, we get the opposite pattern with the trimethylated histone tail of H3K27, so we often use both of these stains combined. About 15% of the cases will also have p53 mutations that cause overexpression and or ATRX loss that you can see, similar to what we get with IDH mutations. So these are the things that in the past we mostly call diffuse intrinsic pontine gliomas, thalamic gliomas, spinal cord gliomas. I've seen some of these in the pineal or cerebellum, but typically they are, as the name implies, in midline locations of the brain. And they're mainly seen in kids and young adults, but I've seen them as old as 70 and 80-year-old patients, so it's not completely a pediatric type of tumor. These have a horrible prognosis, unfortunately, and this is why they're grade 4. Even if they look like they're lower grade on a biopsy, they behave like they're grade 4. So here's the first two of these subtypes that we kind of talked about earlier with this paper from the Germans in 2012. Here's this third one that was identified. There wasn't quite enough information about this subtype in the last WHO, but I will tell you that it will certainly be involved in the 2020 WHO and has somewhat of an intermediate prognosis between the more favorable IDH mutant subtype the really horrible H3 mutant diffuse midline gliomas or the poor prognosis adult type of glioblastomas. So these tend to be hemispheric, so instead of midline, they're lateral. And about half of them in the past have been called glioblastoma or high-grade gliomas, and about half have been called PNET because they often are extremely cellular, but they typically are infiltrative and sometimes resemble PNET. So this is another mutation in histone 3, but now in amino acid 34. And this converts guanine to either arginine or valine. We have antibodies for both of those mutant proteins, and we just usually pool the two together because the biology of the two are the same. Nearly all of those, excuse me, are also going to be p53 mutant and ATRX mutant, and so we get this pattern of p53 overexpression, ATRX loss, and unlike many other gliomas that usually are positive for OLIG2, these are consistently negative for OLIG2. So if I see a tumor in a kid or young adult that's IDH wild type or is negative with immunohistochemistry for IDH1, but has this pattern of p53 and ATRX, the first thing I'm going to think about is these H3G34 mutant gliomas. So right now, this is a subtype of IDH wild type. It's going to be separated out into its own entity in the next WHO. Will probably be called something like diffuse hemispheric glioma H3G34 mutant. So now we can start to put together these Vogelgrams, basically like you get in the colon in the old days, of how we derive certain molecular subtypes of diffuse gliomas. So there is a big category that is IDH mutant, and if you superimpose p53 and ATRX mutations, it goes down the astrocytic lineage. If you superimpose TERT mutations and 1p19q codeletion, goes down the oligodendroglial lineage. A big category that's IDH wild type, often with EGFR amplifications and or TERT mutations. These are in adults, the GBMs that we've classically thought about. This one will probably break out, and there may be a couple of other rare subtypes that break out of this. We have the midline tumors that are histone 3 K27M mutant. And notice I haven't spent any time at all talking about oligoastrocytoma, which used to be something we argued about for hours among neuropathologists. The reason I haven't mentioned it is that if you do the molecular testing, essentially there are no oligoastrocytomas or exceedingly rare cases where there's mixtures of the two tumors spatially distinct. So this is becoming basically an extinct diagnosis if you're doing the molecular testing. So for those people that are out there and don't have many resources, don't even have the antibodies, or maybe other parts of the world, again, how do you get around this? Even telling IDH mutant or not. So we added this category. So of course NOS, if you're Vin Diesel, is nitrous oxide system, but if you're the WHO, it stands for not otherwise specified. And this is the way around it. So if you add NOS to any diagnosis, for example, oligoastrocytoma NOS, that tells the oncologists and everybody else molecular testing has not been done, or for some reason was not definitive. And so it's not that uncommon. Maybe a patient gets a biopsy in a small community hospital and you start off with an NOS diagnosis, and then maybe they follow up their therapy in an academic center, and then the molecular testing is added and a more specific diagnosis is eventually derived. So what about the issue of grading gliomas? This is another big controversy, and it's been problematic and really wasn't solved by the WHO 2016. So all of the criteria that we've been using over many decades for grading astrocytomas and oligodendrogliomas came before any of the molecular testing was done. And so the question then arises, do these criteria still work with molecularly defined gliomas? And the answer, at least in IDH mutant cases, is not so well, it seems like. There's some mixed results in the literature, but most of them show that you're, at least for grade 2s and 3s with astrocytomas, the classic criteria are not very good at stratifying those tumors. And mitotic index here again, not very good at stratifying those tumors in the IDH mutant gliomas. So this is a problem, and we frequently talk about this in tumor board and say, what does this mean? It qualified histologically as grade 3, but the prognosis, because it's IDH mutant, is probably still going to be very favorable, and the grading really doesn't mean quite as much as it used to. So we looked into this a while back, and then there was a much larger study by the Heidelberg group in 2018. Both studies suggested that homozygous CDKN2A loss is a powerful predictor of aggressive behavior in IDH mutant gliomas. And so this is going to be another a molecular grading criterion in the next WHO, almost certainly. It would probably be used for designating grade 4. Okay, so spent a lot of time on the diffuse gliomas. Just to mention a couple of other very common biomarkers in gliomas that involve BRAF. One is looking for BRAF fusions. This characteristic fusion is mainly seen in pilocytic astrocytomas. It can be a diagnostic marker and a predictive marker because some of those cases respond pretty well to MEK inhibitors, but not as much of a prognostic marker at this point. And the problem is that only about 70% of pilocytic astrocytomas have this alteration. So a negative does not exclude the diagnosis of pilocytic astrocytoma. At this point, we don't have any immunohistochemical surrogates for that. BRAF V600E mutation, you can add to the long list of other tumors. There are several tumors in the brain that can have this mutation. Most commonly PXA and gangliogliomas, but a few other rare subtypes as well. And BRAF inhibitors and MEK inhibitors are probably useful in these tumors as well. So in pediatric cases, we're often asked to do one or both of these BRAF type of testing. So we do have an immunohistochemical surrogate for BRAF V600E. I will say often the staining intensity is not nearly as great as what we see with our controls, such as melanomas. And also in ganglioglioma, for some reason, it's mainly the ganglion cells that stain intensely, and the glial cells can even be negative. They probably just express very low levels of the mutant protein. So just be aware, if you have a ganglioglioma that's glial predominant, you may have to look around for the positive ganglion cells on the immunostain. So BRAF by itself is not all that diagnostic, but if you add the combination of that with homozygous CDKN2A deletion, that's almost pathognomonic of PXA. Not quite. There's a couple of other things that can do that, but really, if you add the two of them together, that's highly suggestive that the tumor that you're dealing with is pleomorphic xanthoastrocytoma. In the pilocytic astrocytomas, I told you this BRAF fusion is about 70% of the cases. The other 30% of the cases all have some sort of rare MAP kinase activating alterations, whether it's FGFR1 mutation, NF1 mutation, or KRAS, NTRK2, things like that. But essentially 100% of pilocytic astrocytomas have MAP kinase alterations, the most common of which is the BRAF fusion. We can pick that up using FISH, although nowadays we often will use next generation sequencing and look at a bunch of markers all at the same time. So we talked about glioblastomas having at least 6 subtypes. It turns out molecularly ependymomas have at least 9 subtypes, 3 that are supratentorial, 3 that are posterior fossa, and 3 in the spinal cord. Most of them have a favorable prognosis except for 2 that have the red dot here. And we do have surrogate stains for both of these. This one was added in the WHO 2016. This one will probably be added in the next WHO. There's been some controversy whether this really is more aggressive or not. Nevertheless, this is now considered its own subtype. So the RELA fusion ependymomas are all supratentorial. They frequently are the clear cell variant of ependymoma. They often have chicken wire-like capillaries, look a lot like oligodendrogliomas, and they activate the NFB-kappa pathway, and you can use surrogate markers like L1-CAM or P-RELA, P65-RELA is another surrogate marker for this. Okay, in the posterior fossa, there's by epigenomic studies, a type A that tends to be much more aggressive, and a type B that has a more favorable prognosis. The type A cases tend to be the youngest kids and infants, type B, older kids and adults, but there is some overlap between those. And so there's no diagnostic mutation for this, but the epigenomic changes cause loss of the trimethylated K27 tail of histone 3, and we do have antibodies for that. So fairly simple to identify with immunohistochemistry the aggressive posterior fossa type A versus the retained expression in posterior fossa type B. Okay, embryonal tumors, another area where there have been big changes. And the most common of the embryonal neoplasms, of course, is medulloblastoma. So this is an old story like the glioblastoma and ependymoma. If you look at genomics, turns out there's at least 4 subtypes, 4 molecular subtypes of medulloblastoma. The consensus now is that there's a much more favorable Wnt-activated subtype, that's maybe about 10% of the cases, sonic hedgehog activated, that's average risk, occurs in infants and in adults. Group 3 is the most aggressive subtype, and group 4 is average risk. And each of these have different genetic underpinnings, and at least these 2 have surrogate immunostains that we can use. So for the Wnt-activated molecular subtype, there's often different clinical trials for this. They're often trying to reduce the amount of radiation that's used and the aggressiveness of chemotherapy. And so often this is the one that oncologists are most eager to know about right away. The main marker that people have used for identifying this is beta-catenin. Now, beta-catenin cytoplasmic expression is seen in virtually all medulloblastomas and many other tumors. But if there's Wnt pathway activation, there's translocation of the protein into the nucleus. And so this is the positive we're looking for. I will tell you I hate this stain because this, if they all looked like this, it would be wonderful. But many of these cases only will stain occasional nuclei. So we've added additional stains to look for the Wnt activated. Another stain is YAP1. This is actually identifies tumor cells in both the Wnt activated and the sonic hedgehog activated subtypes of medulloblastoma. And my favorite of these stains is LEF1, which is often used in HemePath. And this is often much more diffusely positive in these Wnt activated, so I like this one the best. ALK is often patchy positivity in these Wnt activated medulloblastomas. The sonic hedgehog activated medulloblastomas, often we get a clue to the diagnosis because most of them are desmoplastic nodular. So even by H&E, we often have a good clue that this is going to be a sonic hedgehog activated medulloblastoma. There are some targeted therapies in these, at least in the adults. They don't work so well in pediatrics, but in adults, there are some targeted therapies. So our main markers, again, YAP1 tends to stain the internodular regions, and then GAB1 is the main marker we use for downstream of sonic hedgehog activation. Now these can be seen in classic medulloblastomas as well, so we still run these markers even if it's not desmoplastic nodular. This can be subtyped further, so most of these cases are p53 wild type, but the p53 mutant or overexpressing tumors have a dismal prognosis, so it's really important to identify these. So whereas the wild type cases tend to occur in infants and adults, these tend to occur in between in kids between the age of 5 and 15. And many of these cases in our experience have been in kids that have either Li-Fraumeni syndrome or Fanconi's anemia. Often, but not always, these also have histologic clues because they often look like the anaplastic large cell variant of medulloblastoma. And p53 overexpression is usually not subtle. It's usually quite extensive in these cases. So that's the Wnt activated and sonic hedgehog activated, but in fact the most common is neither. It's either group 3 or group 4, and those two overlap quite a bit. So it's often difficult to separate those two, and this term has been introduced as non-Wnt, non-sonic hedgehog medulloblastomas. Most of these are the classic histologic subtype. This is about 60% of the cases. And with the AP1, we're looking for the nice internal control, but negative tumor cells within the AP1 stain for the non-Wnt, non-sonic hedgehog molecular subtype. That said, I will tell you that you can only get so far with the immunoprofile. I mean, you can get pretty far, but essentially all of our medulloblastomas, especially the pediatric medulloblastomas, we will also do next generation sequencing. Other people will do methylation profiling and a variety of other things, but there's a variety of ways of getting better at subtyping these. We try as often as possible to pair the tumor testing with germline because this is one of the most common tumors to be associated with a hereditary tumor predisposition syndrome, especially the sonic hedgehog cases. So this was a case that was sonic hedgehog activated in an infant and has the SUFU germline mutation in addition to tumor mutations. This is a type of Gorlin syndrome, basically. Okay, atypical teratoid rhabdoid tumors, another type of embryonal tumor, mainly affects infants, has a horrible prognosis, although the oncologists now have made some progress in terms of therapy, and it's not nearly as much of a death sentence as it used to be, though it's still quite an aggressive tumor. The vast majority of these will have mutations in the SMARCB1 gene that encode the INI1 protein, and you look for loss of expression, very easy by immunohistochemistry. A very tiny subset of these tumors will instead involve the SMARCA1 gene that encodes BRG1, but these are quite rare. So you have to have either loss of expression of one of these stains by immunohistochemistry or inactivation shown by molecular mechanisms in order to make this diagnosis. A new category of embryonal tumor in the last WHO is this one, embryonal tumor with multi-layered rosettes. And this subsumed a couple of prior diagnostic entities, so ependymoblastoma and embryonal tumor with abundant neuropil and true rosettes. And a subset of medulloepitheliomas are now this molecular entity. It has these characteristic multi-layered true rosettes, often a lot of neuropil, and it has a defining genetic alteration that's an amplicon on chromosome 19. So we can pick this up either by next generation sequencing, copy number plots, you can see the amplicon, or by FISH, you can identify these. So it's called embryonal tumor with multi-layered rosettes. Chromosome 19, it's a microRNA cluster, so this is what the MC is. C19MC altered, typically this amplicon that basically defines this entity. Also involves infants, very poor prognosis, highly aggressive tumor type, very similar to ATRT in that respect. And our immunostain, that's a surrogate marker for this, it's not perfect, but pretty good, is Lin28. And again, you can see some of these p-nets in one of this older study. If there was Lin28 positivity, much worse prognosis. Now turns out to be this entity of embryonal tumor with multi-layered rosettes. Now, one of the things that happened in the WHO 2016 is we got rid of the term PNET. So there's no more primitive neuroectodermal tumor. And actually, in the bone and soft tissue WHO, they got rid of it back in 2013. So there's no peripheral PNET either. So essentially, we stopped using this term because it was felt it was too nonspecific. Too many things got thrown into that category. Unfortunately, to some extent, we've replaced one garbage term, PNET, with another, and that is this category, CNS embryonal tumor NOS. So if it's an embryonal tumor and it doesn't fit any of the other known entities, we're using this category. But the hope is that over time, as we identify the rare subtypes that are within this category, this diagnosis will essentially disappear, analogous to what happened with oligoastrocytoma. So let me give you an example of a case of how we used the WHO 2016. 34-year-old man presents with confusion, 6-centimeter mass identified, patchy enhancement on imaging, and it's resected, shows these features, some round cells with clear halos, some irregular cells intermixed. Many of these cases, in the old days, we would have called oligoastrocytoma. There's microvascular proliferation, thrombotic thromboses, necrosis. So it looks high grade. So we start off with our histologic impression, oligoastrocytoma or some sort of ambiguous diffuse glioma with atypia mitoses, microvascular proliferation and necrosis. So the WHO grade at the beginning is at least grade 3. If it's an oligodendroglioma, glioma, it's grade 3. If it's an astrocytoma, it's grade 4. So at the beginning, molecular studies are pending, and the integrated diagnosis would also be pending. And there's a few possibilities. One, if we find IDH mutation and 1p19q codeletion, becomes an anaplastic oligo, grade 3, but that patient has an average survival of nearly 15 years with therapy. It could be IDH mutant, but 1p19q intact and maybe with ATRX loss. That's a GBM, that's IDH mutant. By the way, this name will probably be changed in the next WHO for the IDH mutant astrocytoma, but GBM, IDH mutant, grade 4. Average survival is 2 to 3 years, maybe a little more than that, so still better than the IDH wild-type GBM, which is another possibility, or you don't do molecular testing and it's a GBM NOS or anaplastic oligoastrocytoma NOS. So in this case, it turned out, fortunately, to be the first one, which is the best prognosis. And now I'm just going to talk about there have been 6 cIMPACT-NOW publications between 2016 and now. One basically was just to clarify NOS, which we've already talked about, and NEC, which we haven't talked about, not elsewhere classified. This is a term that's essentially used for anything that's descriptive. So if you're making a diagnosis that's not in the WHO. So again, anaplastic oligoastrocytoma, no molecular studies, NOS. But let's say the furthest I can go with something is glial or glioneuronal neoplasm. You can look in the WHO, you're not going to find that entity. So that's not elsewhere classified if you want to put that on there. Again, right now, the IDH wild-type high-grade glioma with the histone 3G34 mutation is not in the WHO, so it would be NEC at this point. The second update was to clarify this diagnosis of diffuse midline glioma with H3K27M mutation. So we thought that that mutation initially was very specific for this entity. We've now had a bunch of case reports of pilocytic astrocytomas, gangliogliomas, and ependymomas that can also have H3K27M mutation, and the prognosis is not as bad as these diffuse midline gliomas. So it seems a little silly, but essentially it has to be a diffuse glioma, it has to be in a midline location, and it has to have this mutation to qualify for this diagnosis. The other clarification was in the grade 2 and 3 astrocytomas that are IDH mutant. Basically, several studies have shown that if you have ATRX loss and or P53 overexpression in those tumors, the chances of finding 1p19q codeletion are pretty minuscule, and so you really don't have to have 1p and 19q testing in those cases. Okay, to me, I think one of the most important updates was update 3, because this is a really common scenario, and that is you find something that looks like a diffuse astrocytoma grade 2 or grade 3, but you find genetic alterations that are typical of GBM. We now know those tumors are essentially early GBMs or undersampled GBMs, and they behave like IDH wild-type GBMs. So if you have that scenario, it's IDH wild-type and any one of these 3, EGFR amplification, gain of chromosome 7 with loss of chromosome 10, or TERT promoter mutation, you can now make this diagnosis that's essentially GBM, WHO grade 4. So here's just a quick example, 44-year-old woman presented with this non-enhancing mass that on imaging looks like a low-grade glioma. Here's the resection. On resection, it looks like a low-grade glioma. Didn't have much mitotic activity, fairly bland, not that cellular, negative for IDH1, retained ATRX, minimal P53, low Ki67. So in the old days, we would have called this a grade 2 astrocytoma. Did additional testing, IDH1 and 2 sequencing came back negative, 1p and 19q were intact. So I call this at least grade 2, and the reason for that is I now know, like other people in the WHO now know, that even though there's a category in 2016 that says diffuse astrocytoma IDH wild type WHO grade 2, if you use that diagnosis, you are guaranteed to be wrong. It will either be this undersampled or early GBM, or it'll be something like a pilocytic astrocytoma or a ganglioglioma, and it just looks more diffuse than you realized. So we did next generation sequencing. There was an EGFR mutation, TERT promoter mutation, gain of 7, loss of chromosome 10. typical features of GBM, and we changed the diagnosis to this long name. I can tell you in the next WHO this is going to be simplified to just GBM IDH wild type based on the molecular criteria. Update 4 is for pediatric gliomas, and these are, we talked a little bit about these, but these are the typical alterations we find in these low-grade gliomas in pediatrics. And 5 just came out recently, and this is talking about using the CDKN2A for bumping up something to a grade 4 IDH mutant astrocytoma. So we had recently, last year, a meeting in Utrecht in the Netherlands to basically talk about all the new entities that are going into WHO 2020, and that is what this paper was just in the last few days was published. So if you want to get a preview of what's coming up in 2020, look at this paper. And Giselle was very nice. She already mentioned this brain tumor rhapsody that's on YouTube. If you want a musical reinforcement of all those biomarkers that we just covered, go ahead and take a look at that website, at that YouTube link.
Right, so Dr. Perry, that was a fantastic talk. It looks like we have some questions centered on interpreting some of the studies that we use for diffuse gliomas. So the first one is, how do you report an ATRX stain when there appears to be a loss in just a subset of the cells?
Yeah, that's a great question. You know, it's possible that there are rare gliomas that have heterogeneity in ATRX, but much more often than that, the mosaic pattern that you see is because it's a finicky antibody, and I think it's just not staining that robustly. So I call cases like that equivocal, typically. I really like to see complete loss in all the tumor cells and staining of the internal control before I feel confident that that's a true result.
Next question is, do you ever see intratumoral heterogeneity in the P53 expression? So some areas have obvious overexpression and other areas essentially have no expression.
Yeah.
And if so, how do you interpret that?
Great question. We do see that occasionally. And I didn't get into it because it's complicated. There's at least one paper that suggests at least 10% of nuclei, strong positivity, correlates reasonably well with mutation, but it's far from perfect. I feel usually better when it's at least half of the nuclei, but P53 is certainly an imperfect stain. So there's really a range of staining. If I really saw an area that's floridly positive in one area and another area with just scattered cells, it's probably clonal evolution. So you've probably got a clone that has gained P53 mutation, which is not an uncommon secondary alteration, both in IDH mutant and wild type. So I didn't mention it, but about 30% of IDH wild type GBMs can also be P53 mutant. So P53 is a little more complicated than some of these other markers.
Thank you. Would you ever classify in a glioblastoma in someone who's greater than 55 years old and is IDH1 negative by immunohistochemistry, would you classify it as wild type for IDH without reflex molecular testing?
So I've used the term likely IDH wild type in those scenarios, and there's two papers, both of which, oddly enough, came up with the 55-year cutoff, saying that it's less than 1% chance that you're missing a non-canonical IDH1 or IDH2 mutation. And I usually feel better again if ATRX is retained. So if I see ATRX loss, I will still be suspicious, even though the patient is older. I'll still be suspicious that there is a non-canonical IDH mutation in that case.
And I think the last one I've got on gliomas, what do you do with the IDH mutant tumors with relative co-deletion of 1p and 19q?
Yeah, great question as well. So, relative co-deletion is a term that's mainly from fish studies. And what it means is that there's loss in comparison to the overall polysomy, level of polysomy, or usually that reflects polyploidy. So let's say you have a tumor that's mostly tetraploid, and most of your tumor nuclei have 4 copies of the control probe and 2 copies of the test probe. That's a relative deletion. That's just as valid as any other deletion. So I still use that as evidence of co-deletion. There's some evidence that with the polysomies, there's a shorter progression-free survival, but the overall survival is not any different. So I don't really pay too much attention to that. So the short answer is it's equivalent to any other deletion.
Okay. And do you recommend using the H3K27M trimethylation as a proxy?
For the diffuse midline glioma?
For the 1p19q co-deletion.
Oh, for the 1p, yeah. That's a, that is a really interesting study that was published a couple of years ago, or a year or two ago. We tried to replicate that, and it's true that the oligodendrogliomas are often will have loss of the trimethylated protein, but there are some astrocytomas that do as well, and not every oligodendroglioma will do that. So for us, we didn't think that either the sensitivity or specificity was high enough to replace FISH or other studies for 1p19q.
All right, moving on from those, there's a number of questions about additional categories and whether they might be added for example, CNS round cell tumors with B-core or CIC alterations, pilocytic astrocytomas with anaplastic features, etc.
Yeah, those are almost certainly going to be added, and I didn't have time to cover them. There's too many. But most of those are discussed in that paper that just came out, the cIMPACT number 6. So you could look that up. I think it's in brain pathology, and that will cover most of those things. Now, there's no guarantee because some of those are controversial and we're still discussing them. So what's in the paper may not be exactly the same as what's in the WHO 2020, but they're almost certainly going to be added.
Now, with how rapidly this moves, do you foresee a time when the WHO will no longer print books and would rather have a website that they update as new diagnoses evolve and change?
Certainly it's possible. I know Ian Cree, who's in charge of the whole series, has been really pushing them out rapidly. So he's been working hard to get 4 organ systems per year, and that way the time span between publications is much shorter than they used to be. But it's a good point. They may decide at some point that they'll just do it electronically instead of in print, but not yet.
Okay.
They're still in print.
And what are you doing with your diagnoses now that we have integrated diagnoses where there's a lot of molecular, it takes time. So how are you reporting that out? How do you do that smoothly?
Great practical question. So usually our immunostains are back in a day or two. And so I will typically issue a diagnosis at that point. If it's not a specific diagnosis, it's essentially the NEC that we talked about, though to be honest, I don't usually add the NEC. I just will I'll go as far as I can. So for example, I suspect that it's a grade 2 oligodendroglioma, but I don't have the FISH. So I might say diffuse glioma IDH mutant favor oligodendroglioma, see comment, or something like that. And then once the FISH comes out or the next generation sequencing comes out, I'll issue a more specific integrated diagnosis.
Fantastic. There's one last question here, and it is, what is your experience with H3K27 expression apart from diffuse midline gliomas? And I'm not sure if that's mutant protein or trimethylation.
Yeah. So the trimethylated certainly can be lost in a number of other things, and it's not always predictable. We use it for example, for MPNST as compared to other sarcomas. Much more common to have complete loss in MPNST, and again, it should be complete loss and not mosaic. The mosaic is really nonspecific. We also use it, as I showed, in the posterior fossa ependymoma, so there's other tumor types. In terms of the H3K27M, mainly the other rare tumors that we're seeing that being positive is pilocytic astrocytomas, the rare, again, ganglioglioma, and ependymoma. So if you have the other classic features of those tumors, at this point, there's no WHO associated with those because we haven't had enough experience. It's probably not nearly as good as the grade 1 for pilocytic, but it's not nearly as bad as the grade 4 for diffuse midline glioma. But we just, at this point, they're mainly case reports, so we just don't know exactly what the behavior is for those tumors.
Fantastic, thank you. At this point, we're about 15 minutes past the hour. So I want to say thank you so much for a fantastic and enlightening presentation, for all the answers to the questions. We really appreciate having you give this virtual pathology grand rounds.
It was great. Thanks for having me.
Great. Thanks everyone for participating, and thank you so much to Dr. Perry, and everyone stay safe and have a good weekend.
Thanks.